PGT-A, or preimplantation genetic testing for aneuploidy, is the most common form of genetic testing in our IVF laboratories. That is where we take a few of the trophectoderm cells out of the embryo and send those off to a genetic testing lab where they will analyze the total number of chromosomes present in that embryo. The total number of chromosomes will give you confidence that that embryo has the chromosomes needed for a viable pregnancy. It will also convey information about biological sex, should you choose to have that information disclosed. It has also been referred to as PGS in the past. There's also PGD, which is preimplantation genetic diagnosis, which has been re-termed PGT-M for monogenic diseases, where families are looking at specific genetic diseases which are known to affect their family. And so we're looking at very, very specific genes and mutations that may affect these embryos.
We need to be able to biopsy off anywhere from 3 to 8 cells of that trophectoderm layer. We can't get any cells off of that layer, and the embryo just isn't ready for us to biopsy it. We keep it another day. The PGS determines if the embryo is euploid or aneuploid. Euploid means normal, aneuploid means abnormal. It could mean that it has too many chromosomes, trisomy, or 2p monosomy. It also determines if the embryo has a specific gene mutation. We have had patients come through for Fragile X, Huntington's disease, cystic fibrosis. We've had them come through for BRCA. When we do the biopsy, we send just a piece of the embryo there and then freeze the embryo, keep the embryo here. This is the part of the trophectoderm layer that we're going to biopsy off. The inner cell mass is right here. And again, that's that part that's going to be the embryonic tissue or the fetus. So we're not going to want to biopsy that off, obviously. This center part right here is where our laser shoots, and then it shoots right at the junction of the trophectoderm cell. So we're going to take this little chunk of the trophectoderm layer off, and the embryo is being held over on to the left side of your screen, and then the holding pipette of the trophectoderm cells is just kind of keeping them so they don't float off. So that's what's happening with the cells over on the right. And you can see the laser kind of flash. And it's just slowly cutting off of those cells away from the main part of the embryo. This is one of the hardest if you're not careful, this will roll and the whole embryo can get sucked up in your holding. Then if you do it too many times, tighten those even more and make it more strong. So then you can't get through them. So it's a little bit tricky. So then it's done.
PGT-A is a fantastic technology for a number of patients, but it does come with some slight risk. There is, of course, risk that an embryo does not survive the biopsy process, although that is very small. However, I think it is evident that there is some subtle stress put on the embryos. That subtle stress is apparent when you recognize that the total number of live births from PGT embryos is actually not as high as you would expect, as if we transferred every untested embryo in that same group. And that's just indicating that low level of stress is risking some of the implantation potential of the embryos. And that implantation or that risk may be acceptable when we are talking about aneuploid rates of 50% or higher. But if we are expecting 75% of our embryos to be euploid or normal, then perhaps we want to maximize the total number of live births per retrieval by transferring each one of those embryos in succession.